Hello everyone. We are going to learn intraoral radiographic anatomy. I have divided this lecture into two parts, mandibular and maxillary anatomy. Learning anatomy is critical for your success in clinical dentistry. Every day, you are going to review radiographs. Unless you know normal anatomy and its variation, you will not be able to identify abnormality or disease. I'll show you the anatomic landmarks on several radiographs. Anatomy varies from one patient to another. Also, the appearance of anatomy varies depending on image projection. You will see that the most difficult landmarks are in the molar region, followed by incisor region. The regions of canines and premolars are easier to learn. Typically, maxillary anatomy is harder to learn than mandibular. So we are going to start with mandibular anatomy. Before we learn anatomy, let's review two terminologies: radiopacity and radiolucency. An object that is radiopaque is very dense in the body. Examples would be enamel, cortical bone, amalgam restoration, or an implant. A radiopacity is light or white on a radiograph. A radiolucent object has low density. Examples could be pulp canal, sinus, ear space, or soft tissues. A radiolucent object will appear dark or black on a radiograph. Let's start with this molar radiograph. We're going to start with different densities. First, we're going to talk about enamel. Enamel is most dense structure in the body and it appears white or light. Under enamel, we have slightly lesser density, and that is the dentin. So dentin is still radiopaque, but not as radiopaque as enamel. So you can see that there are two different density from enamel to dentin. Under dentin, we have a lesser density, or actually a radiolucency, and that's the pulp chamber. So pulp chamber is here, and this is less dense. Somewhere by the dentin, we have a layer of cementum. The density of cementum and dentin is identical on a radiograph, so it is impossible on a radiograph to differentiate dentin from cementum. So density of dentin, cementum same, and pulp chamber is radiolucent, same with pulp canal, also radiolucent. On the side of the tooth, we have a radiolucent line, and that line goes all around the roots and is called the PDL space or periodontal ligament space. Outside of the PDL space, we have a radioopaque line, and that is called the lamina dura. The lamina dura is a radiographic finding on a patient's body. This structure will be known as the outline of the socket. We also have trabecular pattern that we see, and we'll show you several radiographs showing you different appearance of trabecular pattern. We are still in the molar region, and we'll spend several slides on molar radiograph. So the third molar is impacted. The crown is facing towards us or away from us, which means that the crown is facing either the buccal cortical plate or the lingual cortical plate. Based on this single radiograph, it is not possible to tell you whether the crown is buccally oriented or lingually oriented. So around the crown of a tooth, we have a radiolucent band. So a band is a thick line and a line is a thin line. So this would be a line, and because it's white, we'll call this as a radioopaque line, and the radiolucent band is a radiolucency is a band because it's thicker. So the radiolucent band, we'll call this as the follicle of the tooth. Outside of the follicle, we have the radiopaque line, and we'll call this as follicular cortication. So this is the follicular cortication. Here is another example of a follicle. So this would be the follicle. A good follicle is about a millimeter or 1.5 millimeter wide. So that would make it a good follicle. We still have a good follicular cortication. On the superior aspect near the occlusal surface, we still have about 2 millimeter wide follicle. So that's normal. I do not see a follicular cortication, and that's perfectly normal. This tooth is erupting. The root has not yet formed. So we are seeing only the crown of the third molar. Here is another example of slightly wider follicle. The follicle is about 2.5 millimeter, and that's the follicular cortication, still a thin line. So it's still normal. The follicle being slightly wider, we may want to call this as a hyperplastic follicle. The follicle may become fairly wide or large. So here the follicle is about 3 or 4 millimeter. On this side, the follicle is about, I'd say, 8 or 10 millimeter. So that wide follicle is not normal. We'll call this as some abnormality, and in fall semester, you are going to learn that this follicle is either a cyst or a benign tumor, and we'll try to differentiate whether this is a dentigerous cyst or an odontogenic keratocyst, also known as OKC, or an ameloblastoma. So this is for our fall semester. Let's talk about good trabecular pattern. A good trabecular pattern is such that if you have a fine pencil, just like I have this pen, you will be able to draw this. So I'm drawing this trabecular pattern. Most of the trabecular pattern would be horizontal. There may be only a few which are vertical, and I may be seeing one here, some vertical structure, but overall these are fine radiopaque lines, almost horizontal. So this would be a nice trabecular pattern. At the same time, let me show you one more structure, a variation of normal and maybe a disease. So we showed you this image earlier, and this is the normal dentin that I showed you. On this side, there's less density, and that may mean some kind of disease. What disease? We'll learn that in the fall semester. We also have some radiolucency here and some radiolucency here. Those are a disease, and we'll talk about this in the fall semester. So this time we are just trying to learn normal anatomy, and later we'll learn about the diseases. Here is another example of normal trabecular pattern. So if you have a fine pencil, you should be able to draw these lines. These are almost horizontal. One thing that I'd like to point out on this slide is this abnormally wide pedial space. So you have to wait a few months before till we go to the fall semester, and that's the time that we are going to identify what this widened follicle represent. Typically, the trabecular pattern will be well defined on the superior aspect. So here I can draw good trabecular pattern. Good trabecular pattern here. On the inferior part, this area has less density, less trabecular pattern, and this is still normal. And we'll call this as submylohyoid depression. We'll learn about this anatomic landmark later. As we look at a sample of a mandible, there are several landmarks we'll try to identify. First landmark we'll try to identify is this, which we'll call as external oblique ridge. external oblique ridge. When we move to premolar region, we'll also identify this structure, which we'll call as mantle foramen. So these are the structures that we'll see. If we look at the lingual aspect of the mandible, there are several landmarks. One is, we'll start from the top, is the internal oblique ridge. This is the internal oblique ridge. Near the molars, we'll see the mylohyoid ridge. This is mylohyoid ridge. For some patients, the mylohyoid ridge and internal oblique ridge will continue together. So in the anterior part, we'll call as a mylohyoid ridge. If we see a ridge in the posterior region, maybe we want to call this as internal oblique ridge. So let's review several landmarks here using the same radiograph. So on the most superior aspect, we have the alveolar crest. So alveolar crest is here. As we come inferiorly, this part is the external oblique ridge. As we come inferiorly, we have the mylohyoid ridge, which goes almost over the molar regions. So that would be the mylohyoid ridge. Then we have mandibular canal. The mandibular canal, you may also want to call this as inferior alveolar canal. So these are different terminologies that we'll use. You have to learn both. We'll call it mandibular canal or inferior alveolar canal. So this is the inferior border of the inferior alveolar canal, and that's the superior border of the inferior alveolar canal. Further inferiorly, this would be the inferior border of the mandible. So this is about 3 or 4 or 5 millimeter thick radio-opaque band. For a normal, that's the width, 3 or 4 or 5 millimeter thick. If it is thin, maybe 1 or 2 millimeter, that may represent disease. And what kind of disease? We'll learn that in the fall semester. We'll also learn about inferior alveolar canal or mandibular canal. So this is the inferior alveolar canal. That's the canal. So this whole area is the inferior alveolar canal. So that's the superior border of the canal, and this is the inferior border of the canal. Here is another example of a canal which is very well defined and corticated. In the previous slide, we saw a superior border of the canal is not very well defined. That's a variation of normal, and this is another normal. Both the canal, the superior border of the canal is well defined, as well as the inferior border of the canal is also well defined. Let's continue to review the oblique ridges. This would be the external oblique ridge here. That's the external oblique ridge. And this would be the mylohyoid ridge. Starting here all the way anteriorly would be the mylohyoid ridge. More examples. That's the external oblique ridge, and this is the mylohyoid ridge. And you can see that there are difference of appearance, and that varies from one patient to another, and also depends on the projection geometry. Inferiorly, we're looking at the inferior border of the mandible. And here is the inferior alveolar canal. So that's the inferior border of the canal, and this is the superior border of the canal. I do not see the margin of the canal very nicely here, and that's also variation of normal. This is the inferior border of the mandible. So we are done with the molar regions. Let's go to the premolar region. And lucky for us, there's only a few landmarks in the premolar region, so we do not have to learn much. We have already learned the trabecular pattern, so that's what we are seeing here. The only area of interest in the premolar region is the mantle foramen. A mantle foramen is an oval radiolucency may be circular. So that's the mantle foramen. The location of the mantle foramen can vary. This one is in the region of the apex of the premolar. Here is another example. The mantle foramen is located between the two premolar roots. So this is the mantle foramen located between two premolar roots. Another example of a mantle foramen superimposed over the apex of the second premolar. And most of the time, this is where you are going to see the mantle foramen. Here is another example of a mantle foramen superimposed over the apex of the second premolar. Sometimes mantle foramen will be posteriorly positioned. So in this example, we have the mantle foramen near the mesial root of the first molar. There is one more landmark I would like to show, or a condition. This radiopacity, we did not see something like this earlier. So we'll call this as a dense bone island or a idiopathic osteosclerosis. We'll learn about this later in fall semester. The inferior alveolar canal may have different shapes. In this case, the canal is here, coming anteriorly and looping. So this is the inferior border of the canal. The canal loops back. Here is the mantle foramen. So it looks like an handle of an umbrella. So that would be an anterior looping of the canal. So this is the looping of the canal, and the canal in this case is not corticated. In the mandibular premolar region, sometimes we will see a mandibular torus. A mandibular torus is typically a bony bump on the lingual aspect of the premolars and canines, most commonly located near the alveolar crest. So this has an increased density, so radiopacity superimposed over the roots of the premolars and canines. So this you may see in many patients. It's not a normal anatomy, but frequently you will see it. So this is the appearance, increased radiopacity. So this whole area is a torus. In the anterior part of the mandible, we have only a few structures of interest. We'll talk about this radiopacity, which is aligned with the midline of the mandible. And several millimeters away from the root apices. So we'll call this as genial tubercle. It's a bony projection on the lingual cortical plate. Genial tubercle is a circular radiopacity at the midline of the mandible, several millimeters away from the apices of the central incisors. The appearance on an intraoral radiographic image is a circular radiopacity with a central area of radiolucency. This radiographic appearance is similar to a bull's eye or a target. On an occlusal radiograph, the genial tubercle is a bony projection on the lingual cortical plate. The central depression is seen as a radiolucency on a periapical radiograph. On a mandibular anterior radiograph, you may see multiple radiolucent vertical lines. These lines are nutrient canals. The canals may open into circular radiolucency or nutrient foramina. This radiograph also shows the presence of nutrient canals. However, there are no signs of nutrient foramina. On the lower corner, the dark lines are fold of a film. When we used film-based radiography, if we could not fit a film in a narrow jaw, we often bent the film a bit at the lower part. Such bends are not done on digital sensors. Typically, on the mandibular posterior regions, we do not see nutrient canals. In this edentulous region of the first molar, the alveolar bone is thin, therefore we can see the nutrient canals. In some cases, we only see nutrient foramina, but do not see the canals. This is a variation of normal. The superior part of the mandible may show low radiographic density. This low density area is called the mantle fossa. If you slide your finger from the chin to the lip, you will feel a bony depression. The mantle fossa is between the alveolar ridge and the mantle ridge. The mantle ridge is the line of contrast on the inferior part of these images. Here is a better example of the mantle ridge. It may have a pyramid shape. The peak of the pyramid is at the midline of the mandible. This is the end of the mandibular radiographic anatomy. Please join me in the next video to learn the intraoral radiographic anatomy of the maxilla. Let me remind you that maxillary anatomy is more complex, so the next unit will be a bit longer. See you then at the next video. Bye. Thank you.